I'm David Erlinge. I'm professor of cardiology in Lund University in Lund, Sweden. The background is that we have very good modern drug-eluting stents, and they have solved most of the problems during the first year that we had with the old stents, and just plain balloon, of course. But the problem is that they cage the coronary artery, and that causes events that continue to accrue over the years. So we have events of around 2 to 3% every year. So at 5 years or 10 years, it can be 40–50% event rates. So we still have a problem with these unphysiological drug-eluting stents that we have today. And the Bioadaptor is a new kind of stent which has helical strands that are held together with locks of a polymer, PLLA. And these disintegrate after 6 months. So after 6 months, the Bioadaptor opens up the vessel, restores pulsatility, physiology, and positive remodeling. So the idea is that this will have long-term effects that will protect the patient from new events. So the INFINITY-SWEDEHEART trial included 2,400 patients, and it was a very broad, nearly all-comer population with a lot of ACS and some chronic also, and up to 85 years old, so very broad population of traditional PCI patients. And it was done in Sweden using, on top of traditional design of studies, we also used our registers, the SWEDEHEART register, to follow the patients. A year ago, we presented the 1-year results of the INFINITY-SWEDEHEART trial. There we met the non-inferiority criteria for 1 year. And then we had a powered landmark analysis showing from 6 to 12 months, because 6 months is where the Bioadaptor opens up. That's where it don't behave as a traditional stent. So from 6 to 12 months, we saw superiority that was significant in favor of the Bioadaptor DynamX. Here at TCT, I will present the 2-year landmark analysis from 6 to 24 months. And the results are very good. The curves continue to separate, and we have a 48% reduction in TLR in those 6 to 24 months. The second part of the question is how it will be used, if it's a complement or if it's gonna kind of replace all drug-eluting stents. And I think in the beginning, like we are thinking in my clinic, in the beginning we have to be rather modest and start with patients that will have this stent for a long time. So not too old, and we focus on the most important stenoses, like the proximal LAD, mid-LAD, and so on, large vessels that we are treating. But in the long run, if the results continue to be as good as they are now, I think it should replace all drug-eluting stents, except in some extreme situation like instant restenosis. The take-home message is that the Bioadaptor restores physiology, and I think that is a very good thing. It should be the best way to treat the patients, but we have to prove it with our results. So it is already used in many countries over the world, not in the US so far. It's not approved yet. And I think most people think, as we think in Lund, that we start with relatively younger, don't have to be very young, but they should have it for a long time and use these long-term effects of the Bioadaptor. And it should be important stenosis in large vessels. That's where we start. And then the future will tell us how good it is and if we should replace most of the drug-eluting stents. The Bioadaptor DynamX is in for the long game, kind of. So it's the long-term results that are the most important. And we have the INFINITY-SWEDEHEART trial that will continue to present data for at least 5 years, but with our registers in Sweden, we can follow the patients lifelong. So and that's one of the reasons for the name of the trial, INFINITY. We also have another trial, the Bioadaptor RCT, that was conducted in Japan and Belgium and New Zealand. It's a little bit smaller. They are 1 year ahead of us, so they already presented 3-year data. But those two studies will give us results every year for some years to come. And that's the most important thing. Then there are a lot of ideas for using the Bioadaptor in different situations. We are talking about vulnerable plaque treatment and so on. So we're talking about CTOs and calcified lesions. I mean, there are a lot of subgroups that can be investigated more, and several studies are ongoing.